record it. That way you have it. I think someone's in the waiting room. Okay. Oh, and make sure to put your SFC ID numbers into the chat for me. Um, but okay. So, basically we have the labor and the birthing process, right? We talked so much about in the other chapters, like what you do before labor, right? Like what we expect the mother to feel during the trimesters and how conception works. And now we're going to be more focusing into the labor process as well as what sorts of things do we expect to see and what should we monitor for after the baby is delivered. So, signs of labor, which are going to let you know that your mom or this lady is definitely going to have a baby, is actually when they have lightening, which is, remember we were talking about when the kind of the stomach starts to descend a little bit, and that's where it makes the mom want to pee more. That is a sign that labor is happening. Having a surge of energy 24 to 48 hours before the onset of labor is also a sign that labor is going to happen. If they have like a mucus plug that becomes brownish red and that shows, that's indicative that, hey, something might be rupturing down there, and this lady is getting ready to give birth. But we also have to be careful because if they have, let's just say, a mucus plug that's like bloody, but there's also a foul odor and vaginal discharge, there could be an infection, okay? So we want to look at that too, because even though when we say, oh, the membranes rupture, we need to look and make sure it's a normal rupture, because if it's infected, that's a problem. Braxton Hicks contractions that become more frequent and consistent is a sign of labor. So if the contractions are coming every 5 minutes, okay, looks like they're getting ready for labor. Spontaneous rupture of membranes, or SROM, right? So they're going to have leakage of that amniotic fluid. And because of that, there's also a risk for infection. But if we see that, the membranes rupture, that's letting us know, hey, this lady's going into labor. Now, the best and only way we could really tell if this lady's in labor, even though all of these things can happen, is if there's cervical changes. If the cervix moves, meaning it dilates, or it has something called effacement, then we know, okay, she's getting ready for labor, because the cervix needs to become soft and shortened and thinned and flexible to help get that baby out. So we have effacement, which is the thinning of the cervix to allow that baby to descend towards the vagina to, come out. And we also have dilation, which is opening or enlargement of the cervix. And that's what we're looking for. And you're going to be seeing while you're studying this how to determine like effacement and dilation and what all of that means. Now, she's definitely going to ask you about the true versus false labor. So, false labor is when there's no cervical changes, okay? So, they're not in labor, even though they might be having contractions. If they are inconsistent in frequency, duration, or intensity, she's not in labor. If the contractions stop or slow down with walking or a change in position, she's not in labor. If they drink water and that also causes the contractions to stop or slow down, they are not in labor. True labor is when we have effacement and dilation, okay? The true indicator. Contractions are going to become regular and more closer together and increase in intensity. The pain is also going to be in the lower back and radiates a bit to the stomach. And contractions are going to continue no matter what she does, whether she changes positions, drinks water, it doesn't matter. She's still going to feel contractions. That's the difference between true and false labor. Now, so for the process of labor, right, we have something called the fetal attitude. She's going to ask you what these are by definition. So, like, fetal attitude is the flexed positioning, right? So when that back is rounded and their chins to their chest, something more lines like how you see how it's really the baby's really close up in these pictures and it's like hugging itself. That's the position that we typically will see a baby in, right? They're going to hug themselves, their thighs are going to be flexed to their abdomen. It's almost looking like a little cannonball for the baby, okay? Fetal presentation is different. So fetal attitude is the posture, and fetal presentation is the part of the body that enters the pelvis first. What part of this baby enters the pelvis area first? So it could be head first, or they could be in like vertex, right? Or cephalic, which basically just means head first. They could be breech, which typically means that either, right, the feet are coming out, right, one foot's up, the legs are like folded where you see in B, right? Different types of breech, and that's not good. Okay, breech will usually mean a C-section. So we never really want a mom to go into cesarean delivery if we don't have to, but if they're in complete breech where their legs and knees are folded together like in B, or we have like the feet up, which is called frank, or footling, which is a foot comes out, okay? That's examples. She's going to give you pictures and ask you like which one is what. So we could see A is the frank breech where the legs are up. B is the complete breech where they're like all folded in. C is a single footing breech. And D is a double footing breech, okay? We typically want the baby to come out head first. So the next thing is fetal position. And it usually has, there's like three things that we're looking for. And this tells us how the fetus is laying in terms of the maternal pelvis, okay? So it's basically describing the location of where the baby is in relation to the quadrants of the pelvis. Is the baby on the right or the left side? That's the first thing that we look at. The second thing we looked at is the presenting part of the fetus. Is it occiput or vertex, meaning head first, or is it breech, sacrum? They're both used interchangeably, okay? But when we're talking about how to identify the fetal position, we're either using occiput or sacrum, and we're using right or left or L and R. We're also looking to see if they're anterior, posterior, or transverse, which is A, P, or T. So anterior means that the baby's back is to the mom's front. So we'll typically see the line of the baby's back in the picture. If you see the line of the baby's back in the picture, that means they're anterior because we can see the spine. Posterior is the baby's back is to the mom's back, which means we can see them. It's like they're facing you. Transverse is when the baby's back is to the mom's hip or they're sideways, okay? And typically when you're doing the fetal position, she's actually going to show you on your exam a picture of the fetal position, and she's going to ask you what it is. And you're going to have to write ROP or ROA or LSA, whatever it is. You're going to have to write it out like that. So that's why I provided like these terms, right? So baby's back to mom's front to help you know how to identify them. And I believe she also gives you a worksheet to help with that. And I believe that's very helpful. Fetal monitoring. So when we have fetal positioning, we need to get the position of the baby so we can know how to place the monitor. She's going to ask you that. So if they're in the occipital position, meaning that their head is first, right? Whether it's anterior or posterior, it doesn't matter. The fetal monitor needs to be placed in the lower quadrant. So if they're in ROA, the fetal monitor will be on the right lower side. If they were in LOA, it would be on the left lower side, okay? And imagine, why does that make sense? Well, if they're on the right side, and their heads down, right? You're going to be able to hear the heart rate better if you're on the right lower side than if you were on the right upper or left upper, right? Same thing if you're talking about LOA. If they're in the sacrum or breech position, whether it doesn't matter if it's anterior or posterior, the fetal monitor will need to be placed at the upper quadrant because that means their butt is down, right? And the baby's head is more towards the upper stomach. So if they're in LSP, which means left sacrum posterior, the fetal monitor will be placed in left upper. It always goes by if they were either on the left or right side. So if it's left posterior, right, it's going to be left upper. If they're in that breech or sacrum, if it's occipital, whether it's anterior or posterior, if it's right and they're in that occipital position, it's going to be right lower. If it's left, it's going to be left lower, okay? And she's going to have, like on your slide, just different positions, and these are just different ways that we can call it. So yeah, remember occipital, if it's whether it's anterior, posterior, it doesn't matter. It's going to be either right lower if it's on the right side or left lower. If it's sacrum and breech, we're talking about upper, either left upper, right upper. Okay. Any questions about that?
Yeah, I have a question. So for the so we use the head or the butt to determine the fetal monitor. So if you're saying that if the head is down and then it's the back that's facing the front, then we know is the left occipital posterior, something like that.
So, do you mean like how to know if it's anterior or posterior? Is
No,
that
I'm
what you
talking
mean?
about the fetal monitor. That's what I'm a little confused at.
Okay, so if it says occipital, which means it's going to be O, right? The middle one's going to be O. If it's anterior or posterior, which is going to be the third letter afterward, right? Doesn't matter if it's anterior or posterior. If they're on the right occipital side, it's going to go on the right lower. If they're on the left occipital side, it's going to be left lower. It doesn't matter if it's anterior or posterior. Okay, we don't really care about that third letter when we know it's occipital. We just have to figure out if it says right or left, then we know where to place the fetal monitor. If it's sacrum positioning, meaning that there's an S in the middle, right, we don't care if it's anterior or posterior as well. So we don't care about that third letter. If it's left, if they're in that left sacrum position, then we put it in left upper. If they're in the right sacrum position, it's going to be right upper. Does that make sense?
You're basically saying like the head is always gonna be lower, and then if we're looking for the occipital, the head is always gonna be like lower, but if it's the sacrum is gonna be upper. I
Yeah,
don't know. I probably
because
have to.
I don't have pictures, but if you're thinking about occipital means that the head is towards the pelvis. And sacrum means that the butt of the baby is touching the pelvis. So the fetal monitor is to check the heart rate of the baby. And the only way that we could do that is knowing what position that baby is in. If they're in that occipital position, where the head of the baby is facing the vagina, then we just have to know if it's right or left. It would be right lower if it's ROA or ROP, and it will be left lower if the baby's position is LOA or LOP, to place that stethoscope to listen for the fetal heart rate and to place those fetal monitors. If we're talking about sacrum, where the baby's butt is facing the pelvis, right? Whether it's anterior, posterior, if it's left, then we're going to put the fetal monitor in the left upper. So if it's LSP, LSA, it's going to still be left upper. If it's RSP, RSA, it's going to be right upper where we place the fetal monitor. Does that make sense now?
Yeah.
Alicia, I have a question. I'm sorry.
Mm.
And when it comes to not just the fetal monitoring, but just like the positioning of the baby. We're always putting it in the perspective like of the mom, like our right, her left, right? If that makes sense.
Let me think about that. So you're saying if we're looking at it, right?
Yeah.
The baby.
Mm-hmm.
Um, okay. I think I know what you're saying. I think if we're looking at the baby, because we're
Mm-hmm.
gonna see it in its stomach, like as if, we could, even though we can't see, as if we could see.
Right.
I think it would be the mom's maternal right.
Right. Okay. And technically it would be our left, but we ignore that and just think about like the mom's positioning, if that makes sense.
Yes,
Okay.
yes, the mom's
Okay.
positioning.
Okay.
There's probably examples in your slides that I don't have that you could see to like
Right.
verify it, but
Okay.
she should label them. Like let me see. I could probably pull up an example on Google, like ROA positioning for
Okay.
baby. Uh, Images. Okay. Uh, Let me see if I could share this. Okay. So can you see my Google search?
Yeah.
Yes.
So that's what I mean when I'm talking about the fetal monitor. Actually, oh, this has a lot of different things, but I'll get to that picture after. This one might be pretty good.
Wait,
So,
Alicia, so sorry. So
mm,
we're using this. So because if it's occipital, the spine is at the bottom. But if it's sacrum, the spine is at the top. That's why we use the lower for the occipital and then the upper for the sacrum. If I'm I don't know.
it's because like, okay, let's look at these pictures, right? So here's the top one, right, where it says right ROA, right? You're gonna place the fetal monitor in the right lower, right? Look at the head. You'll know the heart, right, is more on the upper part of the body. So if we put it in the right lower, we're gonna hear that fetal, and we're gonna be able to get an accurate fetal heart rate. If we were to put this in right upper, we'd be by the baby's butt. And you're not going to be able to really get an accurate heart rate reading from assessing it from the baby's butt area. Same way if you're coming over, where is it? I'm trying to look for LSA, right? So if you look at LSA, right, we're going to do left upper because that's where the baby is, where that heart is. If we did left lower, we'd be by the butt again.
Oh, so it's more about the heart being above the pelvic.
Yeah, where it is, right? So, for
Right.
example, right, if the butt's by the pelvis, we're not going to put the fetal monitor there. We're going to put it wherever the baby is. So, if they're left upper, if they're left LSA, then we're going to do left upper.
Yeah, because it's above the pelvic and the heart is, yeah. Okay, that makes sense now. I was a
Okay,
little
yes.
confused before.
Yeah, I didn't have pictures, so I hope this makes more sense looking at visuals, right? So like you could see even LSP, right? It would still make sense to have left upper. It wouldn't make sense left lower or right lower. You wouldn't hear anything. You wouldn't get an accurate reading. But that's what she's going to ask you. If they're in one of these positions, whether LSA, LSP, whatever, ROA, LOA, whatever, where do you put the monitor? And you'll have to know how to do that. But I hope that helps. Um, okay. So yeah, that's positioning. You have to like memorize the positions because she's gonna give you like examples like pictures like those and ask you to identify what fetal position they're in. That's why I wrote here. Anterior means baby's back is to mom's front. Posterior means baby's back is to mom's back. So it helps me with understanding. And then transverse just means the baby's sideways. Okay, so remember, whether it's in sacrum, whether it's anterior, posterior, we don't care about the third letter. If we see sacrum, we know we do upper, whether right or left, depending on which side. If they're left, is left upper, right, right upper. If they're in occipital, whether it's anterior, posterior, who cares about the third letter? If we see RO, then we know we do right lower. If we see LO, then it's going to be left lower. Okay, so We also have stations and engagement. So when we're talking about these different things, we need to understand the terms. So, right, dilation, we were talking about, how much the cervix dilates. Effacement is how close, right? Let me just double check. I don't want to say the wrong thing. Is the thinning of the cervix. So how much that cervix is thinning, which is allowing the baby to descend. So usually the effacement can go in like from like 0 to like 100. Dilation will go from like 0 to 10. And the station is the relationship of the fetus to the bony pelvis. And meaning, how far is that baby descending, right? So let me see if I can get another picture of fetal station. So it makes more sense. Sorry. Oh, I'm like losing everything. Okay. So, this is what fetal station means, right? How far that baby's coming down. And it starts with -5 and it ends with +5, okay? And +5 means the baby is out of the vagina, and -5 means that that baby is really, really like far away from getting to the pelvis. So, we usually call the negative stations the baby is still floating, and we call the positive stations that the baby is in the vagina. And now 0 station is what we call engagement, which means the head is at the spine. It's called 0 station, and it's also called engagement. And what we love about 0 station is that there's no risk of an umbilical cord prolapse, which you can correct me if I'm wrong, but I believe an umbilical cord prolapse is when like the cord can sort of tie around the baby's neck. And that's not good. Okay. So, there's also fetal movement, right? So as they're moving down, as they're going down the pelvis, right? As they're going through, we have a certain set of movements that we expect the baby to do. We call these the cardinal movements. So first they need to get into 0 station, right? And professor had this little like mnemonic that was every darn fool in Egypt eats raw eggs. So the first E stands for engagement when they get to 0 station. The D stands for descent. So now they're coming down the vagina. Then they go into F, flexion, which is when the chin goes to the chest. Then they go into I, or internal rotation. The baby turns, and that anterior shoulder comes to the pelvic bone. Then they have extension, where the head starts to come out of the vagina. Then they do another rotation called external rotation, where now the baby turns again so they can get the other shoulder out, that posterior shoulder. And then there's expulsion, where the baby comes out. Oh, I don't know why I did that. But what I want to show you is if I can move this thing. I don't know why I can't move it. I wanted to show you the fetal, like how it looks. So, the cardinal movements for the baby. Let's see. So I could show you an image, but just so you can see what this looks like. All right. So yeah, that's what I'm talking about here. So here's the engagement with the 0 station. Then they go into descent. Then they go into flexion, where the baby like tightens up more in a ball. Then we have internal rotation, where that anterior shoulder tries to come out. Extension, where that posterior shoulder comes out. Now both shoulders are out. Okay. Then the external rotation is where we can actually get the head to pop out. And then expulsion, where the whole baby comes out. Okay. So that's why It's just really important to like get visuals and things so you can understand this because a lot of it can be very visual. But yeah, that's what we're looking at when it comes to the baby. So she's definitely going to ask you like what happens in each. So knowing what happens in each of these cardinal movements is very important. So remember the rotations, we're talking about shoulders and extension, the head comes out, things like that. She's going to ask about it. Okay. Now, something else that happens during labor is that we have contractions, right? We have these uterine contractions in that first stage of labor. And the goal in that first stage of labor is to push the fetus downward. And we get complete effacement, 100%, and we want to get dilation to 10. That's what happens. So when we're pushing, the baby's pushing down, the goal is to get to 100% effacement and 10 centimeters dilation, which means that the cervix is as thin as it can get and that the vagina has dilated, that cervix has dilated the most it can. So now in stage 2, in that second stage of labor, they could start pushing down even more to really get that baby out. So when we're thinking about uterine contractions, we're thinking of, right, the frequency. When does one start to the beginning of the minute of the next? How long does one contraction last in seconds? What is the intensity of the contractions, right? We can objectively palpate that by putting our hands on the abdomen to palpate the uterus at the fundus. We could have mild would mean it's soft, so it's not so intense the contraction. If it feels like moderate, meaning it's like a push in, you could push in a little bit on the fundus. That's moderate. So if the uterus is soft, that's mild. If the uterus feels like you could push it in a little, not really, moderate. And if it feels like a board, like a really hard board, that means the uterine contractions are very strong. And the subjective part of it would be what the patient tells us, okay? But contractions, uterine contractions specifically, we're talking more about first stage and second stage, okay? And I already said effacement goes from 0 to 100 and 0 to 10 centimeters. And just for like visuals, a cervix dilating at 10 centimeters is as big as a full roll of toilet paper, if you didn't know that. So if you're ever looking at, I remember when I learned that in class and I looked at toilet paper, I never looked at it the same way because I'm like, this is how big the female cervix gets to push out a baby. And then it goes back down when it's done. I find that incredible. It goes back to like a coin or something like that. It's crazy, I think. But okay. Then we have different responses from the mom, right? We have right, the heart rate and cardiac output's going to increase during labor. Blood pressure increases during contractions, respiratory rate. I mean, doesn't that make sense? Your body's really stressed out. The body's trying to push out a baby. I mean, I wouldn't expect any of those things to decrease. Gastric motility and food absorption decreases. Why would they need that right now when, they're in the middle of labor? And white blood cell count can also increase. That I'm not sure why, but I would know that. But, okay. Fetal response to uterine contractions, okay? So an issue is that during contractions is that the placenta circulation can be cut off a little bit. The placenta starts getting compressed as the baby's trying to get pushed out, okay? So strong labor contractions can actually stop the blood flow to the baby periodically. That's bad. So we need resting time. She needs time to recover before we push. That's why they don't just say push, push, push. You have to push and you take a break because it's blocking blood flow to the baby as the contractions are happening, okay? So, what else? Now we're going to talk about that first stage. So the first stage is all of those contractions and getting to a dilation of 10 centimeters and effacement of 100, okay? And actually, the first stage alone has its own like sub stages. So we have the early and latent phase of labor. So during that early phase, the cervix is dilated to 0 to 6 centimeters around, and effacement is as high as 40%. Typically, in that early first phase of labor, the frequency of the contractions are a little irregular and becoming more regular every 5 to 10 minutes. When contractions become every 5 minutes, they must go to the hospital. The duration of the contractions are usually 30 to 45 seconds, and the intensity is usually mild to moderate. For maternal characteristics, how she's feeling, maybe independent, anticipatory, excited, happy, a little bit of everything, maybe grimacing with contractions, right? But they're still you could still talk to them, and they're very social and things like that. In the active phase, the cervical dilation is 6 to 10 centimeters, okay? And the effacement is between 40 and 100%. The contractions are now every 2 to 5 minutes, not every 5 minutes, so they're becoming more frequent. They're lasting longer, now 45 to 60 seconds instead of 30 to 45. The intensity is increasing too, it's becoming more moderate and strong. Now the mom is having like a bloody show down there. She's very anxious. She doesn't have good coping skills. She's hyperventilating, diaphoretic, and this is the I can't take it anymore phase, okay? Legs cramping, nausea, not good. So think beginning, okay, she could still talk, she's okay. Second, by the active phase in that first stage of labor, not so good. The second stage is when they're pushing until the baby is born. So they already are at dilation of 10 centimeters and full effacement of 100%, okay? And usually the birth it could take up to like 3 hours once they get into this stage, okay? So remember, the cervix is dilated 10 centimeters and they've reached full effacement. So now the baby has the presenting part of the fetus. There's the scent of that. You could see the baby coming through the pelvis. Okay, we have voluntary pushing efforts where she's bearing down, and involuntary laboring down with the uterine. So the uterus is contracting to get the baby out, and then the mom's trying to push the baby out. You could see crowning where the head is actually on the perineum, and the baby gets delivered. And the first thing that you do, your priority when the baby is born, is skin to skin contact between the mother and the baby for temperature control, because temperature control is very vital for babies, okay? They don't have temperature control, they can go into like respiratory distress, and it could be really bad, okay? The third stage of labor is when the placenta is delivered, okay? This will take maybe 30 minutes, it could. Basically now that the baby's out, the placenta is going to come out too. And the uterine contractions continue, but because the baby's born and they have the baby on their, like they're holding the baby, they're not really noticing the placenta coming out. It's like the least of their worries now that their baby's born. There's lengthening of the cord and gush of blood. And after the delivery of the baby, the standard care is to administer Pitocin, which is also oxytocin, via IV to contract the uterus and keep it rigid. Why? Because we need the uterus to stay rigid to prevent hemorrhage, okay? That's essential. Postpartum hemorrhage is very scary, okay? For the fourth stage, this is just the postpartum assessments. Now we're talking about right after that placenta's been delivered, we're in the fourth stage. We're looking at the physiological adjustment, stabilization of both the mom and the neonate. We're trying to, if they have an episiotomy or they had to cut into the rectum or the rectum tore while giving birth, they're going to fix that up and do a postpartum and newborn assessment. Is there any questions regarding that? Okay. All right. That's a no. Okay. So now the next chapter is about nursing management during the labor and birth process. So during labor, right, here's your priority order. I wrote out my notes in priority, so this should be great. It tells you exactly what you do first, second, third, whatever. So priority is assessing the fetal heart rate and contractions. That's your priority during labor. Then maternal vital signs, then level of pain, and then status of membranes, okay? We're looking at to see with those status of membranes, have they ruptured? Because if so, that baby has to be delivered within 24 hours. If not, they're at risk of infection. We don't want that. Baby must be born within 24 hours when those membranes rupture. Now, if there's no bleeding, we'll do a sterile vaginal exam, which is going to tell us the dilation, effacement, and station. We already talked about those. The presentation, right? Is it vertex or breach? And the integrity of those membranes. Are they intact? Are they bulging? Or are they ruptured? When the membranes rupture, the priority focus is assessing the fetal heart rate. Even we said during labor, our priority is fetal heart rate, okay? We want to identify if there's any decelerations, right? Because that could indicate cord compression. Not good, okay? So this is just examples of effacement, dilation, and station, how they could be written or how you can write it. So the 50 effacement, 2 centimeters dilated, and they're at -3 station. Okay, that means they're floating. 0 means 0 station, engagement. And we said we like that because it reduces the risk of prolapse, umbilical cord prolapse. Okay, so we have assessing of the uterine contractions, and we're looking at, we already talked about the frequency. You need to know what this means. Frequency in minutes from the start of one contraction to the start of the next. Duration in seconds. How long does the contraction last in seconds? So frequency is in minutes from the start of one to the next, durations in seconds, and we talked about the intensity. Okay, we do objectively or subjectively. Now, we also need to assess the amniotic sac. So basically, the amniotic sac is, remember, we're talking about that fluid, and it could be either a spontaneous rupture or an artificial rupture. Spontaneous is on its own, or artificial is somebody trying to make it pop, right? If it didn't pop when it was supposed to, okay? So the amniotic fluid is alkaline. The pH should be between 6.5 and 7.5. That's what we're looking for. The characteristics of that, when it ruptures, it should be clear. But if it's cloudy, if it's foul smelling, if it's anything like that, if there's a meconium, which is stool, if we see that, that's not healthy, because healthy babies do not poop, all right? So if they did that, that means they're not well oxygenated. And if there's blood, if we see any of that in that rupturing of the membranes, not good. Remember, mucus plug can have reddish, brownish tint to it, not the amniotic sac rupturing, not that, okay? So assessment of the fetus, right? Priority is fetal heart rate, right? And then we can look at fetal oxygenation status by fetal heart rate and watching the patterns on the fetal monitor, right? Assessing the intensity of the uterine contractions. We said the stronger they are, that means there's, blood flow cut off. So we have to watch that. We need to look at the status of the amniotic fluid. That tells us a lot if it's a healthy or non-healthy baby. We said if we saw meconium, not good, and we want to do maternal vital signs. We also want to do continuous electronic monitoring, okay? So we have external, which is like an ultrasound transducer on the lower abdomen. And we could also use for uterine activity something called a tocodiameter or a tocotransducer on the upper abdomen, okay? So those are some things that we could do to analyze movements. Internal, that means we're actually going inside, right? That pelvis area. Not really good, because the amniotic sac needs to rupture before doing this, or else we could rupture it, and that's really bad, okay? But these are more accurate. So if we use that, it'll be a fetal scalp electrode. And if we're looking for uterine activity, we're gonna either do an intrauterine pressure catheter, but these aren't done by RNs. This type of one, the intrauterine pressure catheter, we don't do that. Okay, so what do we need to know, right? The average fetal heart rate, right? Rounded to 5 beats per minute for at least 2 minutes, right? It's not exactly accurate, the fetal heart rate. It's not exactly that. The fetal heart rate isn't like a consistent number all the time. But we look at it within, a 10-minute window frame, and when the uterus is at rest. And it should be between 110 and 160 beats per minute. If it's less than that, it's bradycardia, less than 110, persisting for at least 10 minutes. And if it's greater than 160 for longer than 10 minutes, we'll consider it tachycardia. So, variability is good. When we see variability, when we see movement, right, on the fetal heart rate, that is good, right? Absent, not good. We could probably need to have a C-section. Minimal, meaning we're looking at this one, right? The BP, or that beats per minute for the heart rate, isn't really changing. See some movement, that's not good. Okay. Remember, we were talking about how to assess fetal heart rate, what it should be, right? Remember, we were looking for accelerations. We were looking for it to at least be, within that certain amount of time, for that like 15 seconds, that we wanted it to be, at least 15 beats per minute over that. Yeah, we're still looking for that. That still applies here. If we have marked variability, right, which is this last one, that means it's greater than 25 beats per minute, and it's usually associated with a cardiac defect. And this one over here is usually absent, okay? It's not really good. So accelerations are great, okay? If it goes, 15 beats per minute above the baseline and it lasts at least 15 seconds, that's good, because it's related to fetal movement and it's reassuring. It shows that there's, the baby's alive and well. Decelerations, not good. Now, we have something called VEAL CHOP, which helps you remember deceleration. So the V for variable aligns to the C. So VEAL CHOP. So the V for variable, the C means cord compression, which means umbilical cord compression. If we see variable decelerations, what we want to do is move the client. We want to change their position, okay? And it usually, when you see variable, it's usually going to show, I think I have a picture, a rapid heart rate decrease. I'll show you when, I'll get to it when I get to the pictures. The E means early decelerations, and it relates to the H in CHOP, which means head compression, okay? That's normal because that's a part of the labor process. And we'll look at the image, okay? When contraction is over, that fetal heart rate is going to go back to normal. The L stands for late decelerations and relates to the P in CHOP, which means placental insufficiency. If we see them, we never want to see this, okay? And this is a big problem. The A in VEAL stands for accelerations, and the O in CHOP stands for okay, it's normal. So, as we said, VEAL CHOP, that's what we want to use. If we have early decelerations, we're talking about head compression. We don't need any interventions because it's normal. We just need to continue to monitor. Here's an example of what it looks like. It only happens, like I said, because that head is being compressed during pushing down during the cervix, during the labor process, okay? We anticipate that she's going to be given birth soon, and we just document, but no interventions other than monitoring and documenting. For late deceleration, we talked about placental insufficiency. This is really bad. If we see late decelerations, we need to stop Pitocin. If not on Pitocin, the priority is to reposition the mom. So this is what I want you to know. If the question said the mom is on Pitocin and they have late deceleration, stop the infusion. If the question doesn't mention they're on Pitocin, the priority is reposition the mom, okay? And then we can give oxygen. But those, I want you to know those are your priorities, okay? And if none of these interventions worked, no oxygen, not repositioning, or stopping the Pitocin, we might need to have a C-section, okay? But remember, priority, if on Pitocin, stop it. If not on Pitocin, reposition the mom, and then give oxygen. For variable decelerations, it looks like this. And the issue with that is that it looks like a U or V shape. And the heart rate can either decrease down rapidly or up rapidly. There's no like specific pattern for this. And just to point out, for early decelerations means that we have a deceleration before the uterine contraction, okay? sorry. The fetal heart rate, when we're talking about early, the fetal heart rate decreases and it happens at the same time as the uterine contraction. So you see with the line how it's going similarly. Whereas for late decelerations, we're talking about when the decrease in the fetal heart rate occurs after the uterine contraction, okay? So early means it goes during the contraction, which makes sense because it's a normal process, and late decelerations occurs after the contraction, okay? And we talked about variable decelerations. It could be either a decrease in fetal heart rate or an increase in fetal heart rate, like a rapid increase. And we also, for variable decelerations, if they're on Pitocin, stop it. If not on Pitocin, priority is to reposition the mom. For fetal heart rate pattern changes and categories, we have a reassuring fetal heart rate pattern, which is category 1, which means accelerations or early decelerations with moderate variability. That's good. Indeterminate fetal heart rate patterns, which is considered category 2. That's variable decelerations with minimal variability, okay? It's really hard to say what they are, but we need to continue to watch them. Non-reassuring or abnormal patterns are considered category 3. This is really bad, okay? If we have this, we might need intrauterine resuscitation, expedite the birth, and we'll typically see this with late decelerations with absent variability. Remember, we want to see variability. If we don't, it's not good. So, if we see late decelerations with absent variability, okay, which is basically going to look like this thing right here. If it looks like that, and you see that on the monitor, your priority is stop oxytocin or Pitocin. If that's not there, reposition the mom. Then your next priority is if it's stop and Pitocin. If they have it on, then your second priority is administer oxygen. If Pitocin, they're not on it, then we reposition the mom as the first priority, and our second priority is to administer oxygen. Our third priority becomes a bolus of at least 500 milliliters of lactated ringers. We'll also do continuous monitoring, looking at vital signs, maybe a sterile vaginal exam. And our fourth priority, if all the interventions didn't work, is to notify the provider, okay? This is the order in which I want you to take if you see a category 3 pattern of late decelerations and absent variability. Okay, so I'm gonna just see how much is left. Okay, I'm not gonna be able to get into all of this now, so I'm just gonna finish this page and then leave it as that. So, okay, pain. We have non-pharmacological pain measurements, right? So we could do cognitive strategies like breathing patterns, doulas, which are skilled people to help you during the process, hypnosis, hyperventilation strategies. You could do sensory strategies like music, imagery, aromatherapy, like smelling things, cutaneous stimulation, like walking, rocking, changing positions, sacral counter pressure, which is really good for back labor if they're experiencing that, light touching, effleurage, I don't know how to say this word, but I know she asked about this on the exam, which is light touching of the abdomen and circular motions can help with distracting the pain. And yeah, I think I'm gonna leave off with that for now.